The subject of this video is the impact that hearing loss has on speech and language development. Every process of speech production is affected by hearing loss. Typically, the greater the hearing loss, the more affected the process. Additionally, both qualitatively and quantitatively, there are differences between those who have mild to moderate hearing loss and those with severe to profound hearing loss. The evaluative analysis often is completed using spectrographic analyses. If some of you have had voice clinic, you may have had an opportunity to look at a spectrograph. And the spectrograph shows the duration, frequency, and intensity characteristics of speech. Typically, these are judged by hearing and speech scientists. So, hearing scientists look at the spectrographic analysis while speech language pathologists listen for perceptual quality. For respiration, deaf, and for all intents and purposes, deaf in this case is going to be referred to as severe to profound hearing loss. Deaf speakers, breathing for life is normal, but they have significant differences for speech production. Specifically, they don't bring in enough air for speech production. Also, they misuse the air that they bring in, causing less syllables per breath. They also use 3 times more air for syllable production than people with normal hearing. And some researchers attribute that to the lack of therapy and the lack of normal auditory sensations. For individuals with mild to moderate hearing loss, there are no differences found in respiration. For phonation, individuals who are deaf have difficulty controlling their laryngeal musculature. So they tend to either hypo or hypervalve their vocal folds. So hypovalving means that they don't have enough vocal fold vibration, and hyper means that they have too much vocal fold vibration. They're also judged to be breathy, and occasionally they display diplophonia. And so diplophonia is when there's a perception of 2 fundamental frequencies coming through. If we look spectrographically, there's a lot of noise in the sound spectrum for individuals who are deaf and hard of hearing. They have changes in their fundamental frequency, and they have a lot of adventitious sounds like and ah, and that affects the overall quality of their speech. And they also tend to be monotone, so they don't have any lack of, or they have a lack of intonation. The voice quality of individuals who are mild to moderate hearing loss are usually judged to be normal or near normal. In terms of articulation, we see omissions, distortions, and substitutions for both consonants and vowels. Research indicates that the intelligibility of deaf speech is around 20%. With vowel substitutions, they tend to be towards neutralization. So most vowels that are used in deaf speech are replaced with the neutral schwa. They also have problems with diphthongs, which is called diphthongalization, where they make a single vowel into a diphthong. Or they make diphthong distortions. For consonants, excuse me, voice and voiceless confusion is very common, especially at the end of words. Place errors are more prominent on less visible phonemes. So less visible phonemes like T and D, they may have difficulty with place errors. Omissions occur in the medial and final positions more often, with the initial position often present. That can alter meanings, especially for plurals and possessives. And individuals have trouble with blends and clusters. Generally, individuals with mild to moderate hearing loss experience some of these characteristics as well, but not to the degree of loss as people who are deaf. In terms of resonance, we see a nasalization of vowels and a nasalization of consonants, although denasalization can also occur. And when that happens, it's thought to be caused by inappropriate opening of the velopharyngeal port. So we're just going to listen very quickly to this quick video of Marlee Matlin, and you should be able to hear some nasalization. So she's talking about working out and watching something on TV. I could not change the captions for that in the middle of this video. So feel free from the PowerPoint to go back and look at that video a little more closer, maybe listen to it and hear the issues that she's experiencing with nasalization, most of her vowels and consonants. Oh, I forgot to say also that individuals that have mild to moderate hearing loss don't have issues with resonance. Okay, and now we're going to turn our focus on language development and the impact that hearing loss has on language development. Specifically for individuals who are pre- and perilingually deafened, so having had hearing loss from birth, before acquisition of language, and during the most important speech and language developmental milestones. So in the first 1 to 2 years, in addition to ongoing problems, we see issues with phonology, syntax, semantics, and pragmatics. So all facets of language development are impacted as well. And really, for those with pre and perilingual losses, there's no difference in, or individuals with mild to moderate hearing loss are going to experience the issues as well as individuals who are severe to profound. So in speech production, mild to moderate hearing losses are not typically affected the same way as individuals who are considered severe to profound or deaf. But with language development, that auditory memory is so important. And so they do experience issues with all facets of language development as well. This also includes not just understanding language, but also written language. So we're looking at oral and written language, receptive and expressive as well. In terms of phonology, kids with hearing loss in particular don't learn phonological processes. They don't have the auditory memory to sound out words, and they rely on what it looks like rather than how it sounds. And we all know that if you don't have phonological processes, then it does impact reading and writing. The interesting thing is that children who are identified early and fitted with hearing aids or cochlear implants early, they learn these phonological processes the same way as individuals with normal hearing do. They're just a little bit delayed because they don't have that process and that auditory memory from day one. They may be a year delayed, but typically in terms of phonology, kids that are treated with hearing aids, cochlear implants, or speech and language therapy are typically close to normal by the time they reach kindergarten. In terms of syntax, most kids, come to school with a set of rules that are already in place, and they can produce an infinite number of word combinations. Kids who are deaf and hard of hearing have significant difficulty with English syntax. And the degree of hearing loss has a major impact on syntax, so much so that profoundly deaf children comprehended syntax at a level below 4 years old without hearing loss. So children with severe to profound losses show delays and deviation with syntax, while children with mild to moderate hearing loss just show delay. Some of the more important facets of syntax that are affected are passive voice versus active voice, WH questions, and object relative clauses. In terms of semantics, there's restricted knowledge and use of semantic functions. And what that means is they have a reduced use of vocabulary. They may plateau around the kindergarten level, and they may experience deviation of any further vocabulary development. A couple of research studies have looked at this in comparison to kids who are mild to moderate versus kids who are deaf, and found that individuals who are deaf typically score below the 10th percentile on the PPVT. So that's pretty significant. Kids with severe to profound hearing loss are at a severe academic disadvantage because of this. And they also have difficulty with idioms and slang And because of that, they may have some issues with peer relationships. Pragmatics, individuals who are hard of hearing and deaf, have difficulty with language and context. And what that means is that they don't know how to take turns. I don't know if anybody has ever come in contact with a person who is deaf, but they aren't able to turn take. They don't know how to come into a conversation, and they don't know how to exit a conversation. So what they end up doing is either hogging the conversation and nobody can enter into what they're talking about, or they never enter a conversation and they just sit there and think they're following along. They also have difficulty maintaining eye contact, and because of the turn-taking issues, they lack the ability to have conversational fluency. Now, when I say, people who are deaf and hard of hearing or hard of hearing and deaf, that doesn't mean that all individuals who are. But individuals who are severe to profound have more difficulties with these issues. And because individuals who are severe to profound don't always access speech through hearing aids, they may continue to have these difficulties. Over time, some of these problems go away and other times they do not. So this is not exclusive to everybody. We're doing a really good job with early identification, and so early identification has really improved speech and language outcomes for kids who are mild to moderately impaired as well as severe to profound. And so that has made a huge difference in our ability to improve speech and language skills in individuals, because we've fit them earlier. The EDDI model is 136. The new guidelines are calling for 1, 2, 3. So identification by 1 month, and then 2 months, and then 3 months for treatment. So it's a significant impact even for kids now, because while we talked about cochlear implants over the summer, the FDA has loosened the restrictions for age for cochlear implants in infants down to 9 months. And from inception for infants, cochlear implant age, except in research studies, had been 12 months. So as of January 1st, the FDA has decreased the age to 9 months. So again, as we continue to provide treatment for kids who are born with hearing loss and deafness, we're seeing better outcomes. But there are always individuals who fall through the cracks, or individuals whose parents prefer them to remain deaf. So, we're still going to see these issues, but we're seeing less and less of them. For frame of reference, chapters 5 and 6 that are posted on Moodle are excellent reviews of how to evaluate individuals who have, to evaluate speech and language issues in individuals who are hearing impaired. In terms of classroom behavior for all of this, is we see that kids who are hearing impaired are less likely to take risks in the classroom. So they don't raise their hand, they don't complete their work independently. They often need assistance with work. That may be part of their IEP process. That may be some kind of an accommodation. But if they don't learn to do some things independently, and if they don't learn to take risks at a younger age, they're not going to learn to do that as an older kid. And again, the lots of research shows that kids with hearing loss have benefited from EDI, and the research studies show less psychosocial issues associated with those as well.